Right now, roughly 95% of breast cancer survivors are suffering in total silence.
Yeah, and it's a staggering number.
It really is. I mean,
Yeah.
they're dealing with a profoundly painful, debilitating condition. And, you know, most frustrating part of all this.
There's actually a highly effective treatment for it.
Exactly. A localized treatment exists right now, but it is completely trapped.
Right, it's locked behind that FDA warning.
Yes, this terrifying FDA black box warning. And it's blocked by extremely hesitant oncologists. So caught in the middle of all this are patients who are just trying to reclaim their quality of life.
Just trying to get through the day, really.
Right. So welcome to today's deep dive. Our mission today is really for you, the listener. We are unpacking a critical and honestly agonizing question.
It's one that comes up in clinics every single day.
It does. The question is, can a woman who has survived estrogen-receptor-positive breast cancer, or ER-positive cancer, ever safely use localized vaginal estrogen?
And it's a question that sits right at the bleeding edge of oncology and gynecology. The stakes here are just massive.
Because the survival rates are so high now, right?
Exactly. Because of these incredible advancements in targeted therapies, the 5-year survival rate for early-stage breast cancer is pushing 90%, which is amazing.
It's a total medical triumph.
It is. But what we are looking at today is, well, the collateral damage of that survival. We're diving into the clinical guidelines from ACOG, which is the American College of Obstetricians and Gynecologists.
And we also have the ASCO guidelines, right? The American Society of Clinical Oncology.
Right, and NAS, the North American Menopause Society. We're synthesizing all their guidance alongside some truly massive recent meta-analyses.
Basically to figure out if that terrifying FDA warning is actually supported by the current science.
Exactly. Because the science has evolved, but the warning hasn't.
Okay, let's unpack this. To set the baseline here, we all know that systemic estrogen therapy is universally contraindicated for these survivors.
Right, absolutely.
I mean, oral pills, high-dose patches, the stuff used to treat general menopausal symptoms.
Yeah.
You cannot give that to survivors of ER-positive breast cancer.
No, because the logic there is undeniable. That specific type of cancer uses estrogen as fuel.
Right. It literally feeds on it.
Yeah. So if you put estrogen into the systemic bloodstream, you risk feeding any dormant cancer cells.
But localized vaginal estrogen is different, right? Like we're talking about creams, tiny tablets, or rings that are inserted directly into the vaginal canal.
Completely different. It has a totally different pharmacological profile.
But to understand why we're even discussing giving any form of estrogen to a patient whose cancer historically fed on it, we really have to look at what the cancer treatments themselves are doing to the body.
Right. We have to talk about genitourinary syndrome of menopause, or GSM.
Right, and specifically the vulvovaginal atrophy part of it.
Exactly. Because the endocrine therapies prescribed to keep the cancer from returning are incredibly aggressive.
Their whole job is to suppress circulating estrogen.
Yes, that is their primary life-saving job. But, you know, estrogen isn't just cancer fuel.
No, it's a structural component.
Right, it's critical for maintaining healthy tissue all over the body.
I like to think of it with this analogy. It's like, imagine you have a massive pipe burst in your kitchen. That's the cancer.
Okay, right.
So to save the house, you shut off the main water valve completely.
Mm-hmm.
And it works. It saves the house.
But the water's off everywhere.
Exactly. Now, the guardia outside, which is the vaginal tissue in this analogy, is completely drying up and dying.
Because it needs a tiny bit of water to survive.
Right, and you can't just turn the main valve back on.
That is a perfect analogy because when we talk about vulvovaginal atrophy, we're not just talking about minor dryness here.
No, we are talking about cellular starvation.
Exactly. Estrogen is what maintains the mucosal lining of the vagina. It promotes blood flow, it keeps the tissue elastic.
And it feeds the good bacteria, right, the lactobacilli.
Right, by promoting glycogen production. And that glycogen keeps the vaginal pH acidic and healthy.
So when you systematically strip all the estrogen away, that tissue literally thins out. I mean, it drops down to just a few cell layers.
It becomes incredibly fragile.
Right. It loses its elasticity, the pH spikes, and you end up with severe microabrasions, recurrent urinary tract infections, and dyspareunia.
Which is excruciatingly painful intercourse.
And the numbers on this are wild. Over 70% of postmenopausal breast cancer survivors on these systemic therapies face this exact syndrome.
Over 70%. And we really have to quantify just how profound that systemic estrogen depletion actually is.
Let's do the math on it.
Okay, so postmenopause, A woman's natural plasma estrogen concentration might hover around 20 picomoles per liter.
Which is already quite low compared to her reproductive year.
Right, it's very low. But when a breast cancer survivor is put on certain endocrine therapies, specifically aromatase inhibitors, that level just plummets.
How low does it go?
Down to 3 picomoles per liter, or even lower.
Oh, wow. So from 20 down to 3.
Yeah, it's essentially unmeasurable at that point. It's basically a rounding error from absolute zero.
So at those microscopic levels, the cellular repair engine in that tissue just shuts down.
Completely shuts down entirely.
So obviously the standard first-line medical response from the oncologist is non-hormonal.
Right, they always start there.
They recommend long-acting moisturizers with hyaluronic acid or polycarbophyll gels and lubricants.
Which is the responsible first step.
But what happens when the cellular architecture is just so degraded that surface-level moisture doesn't do anything, like it doesn't stop the friction or the micro-tearing?
Well, that is the breaking point for the patient. When non-hormonal options fail, the scientifically obvious next step is localized vaginal estrogen.
To revive those specific tissues without flooding the whole body.
Exactly. But as you mentioned in the intro, we hit this massive regulatory roadblock.
The black box warning.
Right. All estrogen products, even these ultra-low-dose localized formulations, carry a blanket FDA black box warning about cancer risks.
So if that regulatory dogma is so entrenched, why are we seeing a pushback now?
Because of the new data.
Right. To answer that, we have to look at what happened when tens of thousands of women basically defied the warning.
Yes. Let's talk about the best meta-analysis.
Oh, this study is wild. It's the 2025 best meta-analysis that was just presented at the South Atlantic Association of Obstetricians and Gynecologists.
And this wasn't some tiny tentative trial either.
No, not at all. They pooled data from 8 massive observational studies. We're talking about over 24,000 patients analyzed for cancer recurrence.
24,000.
And over 61,000 analyzed for mortality.
It's a huge data set.
Huge. And the bottom line findings were stunning. Using vaginal estrogen did not increase breast cancer recurrence.
Right.
It did not increase breast cancer-specific mortality. And it did not increase overall mortality.
It's an incredibly robust piece of evidence. It directly challenges the whole assumption that any estrogen whatsoever equals a death sentence for these survivors.
Here's where it gets really interesting, though. I want to push back on the specific numbers in the BESTA study, because when you look closely at the data, it almost sounds like science fiction.
The recurrence rates.
Yes. The study actually recorded a lower risk of recurrence for the women actively using vaginal estrogen.
Which sounds completely counterintuitive.
Right. The recurrence rate was 11.6% for the estrogen users. But it was 15.8% for the non-users.
Yeah.
And it also showed a lower risk of overall mortality. Biologically, that just doesn't track. Estrogen doesn't protect against an estrogen-fed cancer?
No, it absolutely does not.
So what is actually happening in the math here?
What's fascinating here is a statistical phenomenon called healthy user bias.
Healthy user bias. Okay, break that down for us.
So it's a form of selection bias that's really common in observational studies. You're completely right. The localized estrogen is absolutely not acting as a shield against the cancer.
Right, that would defy basic biology.
Exactly. Instead, you have to think about the behavioral profile of the patient who actually gets prescribed this medication.
Oh, like who is actually walking into the clinic asking for it?
Precisely. Who goes to their doctor to advocate for a solution to painful intimacy?
Probably someone who's feeling pretty good overall.
Yes. Generally, it's a woman who is already feeling healthier. Her cancer treatments are going well. She has the baseline energy to actually be sexually active, and she has the health literacy to demand a better quality of life.
Ah, okay. So the treatment group inherently selects for survivors who already have a better physiological and psychological prognosis.
Yes. The healthier survivors are the ones actively seeking out the vaginal estrogen. So it mathematically skews the data.
It makes the estrogen look protective.
Right, when in reality, the estrogen use is just a biomarker of a patient who is already thriving.
Wow. And we see that bias corrected beautifully in the 2023 Eggerol study out of Johns Hopkins.
Yes, that study was crucial.
They looked at a database of over 42,000 women. But crucially, they used propensity score matching.
To account for exactly those biases.
Right. They matched women with similar health statuses and tumor characteristics. And once they leveled the playing field, they found a highly comparable recurrence risk.
It leveled out perfectly.
It did. It was 17.6% for the women using vaginal estrogen and 17.1% for those without.
Statistically, that is a wash.
Total wash.
Yeah.
It proves the baseline risk doesn't broadly spike just because a localized estrogen cream is introduced.
Which forces us to ask a really uncomfortable question.
Why are doctors still so scared of it?
Exactly. If the largest cohort studies in the world demonstrate general safety, why are oncologists still so vehemently hesitant to sign off on these prescriptions?
Because the data gets incredibly nuanced when you look at the specific drugs these survivors are taking.
Right. Breast cancer survivors aren't a monolith.
No, they're not.
Mm.
And the safety of vaginal estrogen is entirely dependent on the specific mechanism of their daily endocrine therapy.
That is the crux of this entire deep dive. We have to clearly separate the two primary classes of adjuvant endocrine therapy used to prevent recurrence.
Okay, so on one side we have tamoxifen.
Yes, tamoxifen, which is a selective estrogen receptor modulator, or a SERM.
On the other side,
On the other side, you have aromatase inhibitors, commonly known as AIs. These are drugs like anastrozole or letrozole.
both drugs have the ultimate goal of starving the cancer, right?
Yes, but their pharmacological pathways are vastly different.
Let me break down tamoxifen first, because its mechanism is fascinating, and it directly explains why it interacts so differently with vaginal estrogen.
It really does.
Think of tamoxifen like a bouncer at a nightclub.
Okay, I like that.
It specifically stands in front of the estrogen receptors on the breast tissue cells, and it physically blocks circulating estrogen from binding and entering.
It bounces them at the door.
Exactly. But the selective part of SERM is the key here. While tamoxifen acts as an antagonist, a bouncer, at the breast, it strangely acts as an agonist down in the uterus and the vaginal tissue.
Like it's handing out VIP passes.
Right. It actually provides a mild estrogen-like stimulation in those specific pelvic areas.
Which perfectly explains the clinical symptom profiles we see in the clinic.
Because of that mild agonist effect in the pelvis, the rates of severe vaginal dryness are significantly lower with tamoxifen.
Yeah, usually hovering around 8% of users.
Compared to 18% or much higher for women on aromatase inhibitors.
Right. So let's look at the pharmacology of this in practice. If a patient is on tamoxifen and her non-hormonal moisturizers just aren't working,
Right.
what happens when she applies a localized vaginal estrogen cream?
Well, because tamoxifen is actively occupying and blocking the estrogen receptors up at the breast tissue, your bouncer's firmly at the door.
The door is locked.
So any minor transient systemic absorption that might escape from the vaginal cream into the bloodstream, it's effectively neutralized.
Right. The cancer cells are already shielded by the tamoxifen.
And this isn't just theoretical. The 2012 Luray-Nested case control study, along with several others, clearly demonstrates no increased risk of cancer recurrence for tamoxifen users who can currently use localized vaginal estrogen.
For this specific group, the safety profile is incredibly reassuring.
But aromatase inhibitors, that is a completely different biological story.
The whole different ball game.
They don't block the receptor doors at the breast. They go after the manufacturing plant.
Yes.
In postmenopausal women, the ovaries have stopped producing estrogen, so the body relies on peripheral tissues, like fat cells and the adrenal glands.
Right, where an enzyme called aromatase converts circulating androgens into estrogens.
And aromatase inhibitors essentially destroy that conversion process.
They shut down the factory.
They drain the entire body's estrogen pool basically to zero.
And that profound total body depletion makes the patient's tissues hypersensitive.
This raises an important question. What happens when you give them localized estrogen?
Well, this is where the pharmacokinetic studies become genuinely alarming. Research like the Kendall study in 2006 and the Wills study in 2012, they investigated what happens to systemic blood levels when you introduce vaginal estrogen to a woman on an AI.
And because her body is so utterly starved of estrogen, the tissues basically act like a sponge.
Right, exactly. Applying even an ultra-low-dose vaginal tablet causes a small but highly measurable spike in systemic estradiol levels.
Wow.
That tiny amount from a local cream absorbs straight into the bloodstream. It essentially reverses the total hormonal suppression that the aromatase inhibitor was prescribed to achieve in the first place.
And the clinical outcomes of that systemic spike are terrifying.
They really are.
In that same 2023 Agrawal study we referenced earlier, they ran a secondary analysis specifically isolating the women who were prescribed both vaginal estrogen and an aromatase inhibitor concurrently.
And the numbers jumped.
Skyrocketed. The risk of breast cancer recurrence for that highly specific subgroup went up to 77.8%.
77.8.
Compare that to 15.6% for the women who used vaginal estrogen without being on an AI.
It is a staggering jump in risk. And, it's corroborated internationally, too.
Right, the 2022 Danish cold study.
Yes, another massive observational cohort. It raised an identical blaring caution flag for the concurrent use of AIs and vaginal estrogen.
When the body's circulating estrogen is that thoroughly eradicated by an AI, reintroducing even a microscopic amount seems to carry a very real documented risk of waking up dormant cancer cells.
Absolutely. So we have this incredibly polarized landscape now.
Yeah, on one hand, for tamoxifen users, vaginal estrogen looks to be a safe, profoundly effective lifeline.
And on the other hand, for AI users, the data suggests it could literally undo their cancer treatment.
So how are gynecologists and oncologists supposed to navigate this practically? I mean, let's look at the actual consensus guidelines from the major medical bodies.
Fortunately, the organizations like ACOG, NAMS, and the British Menopause Society, they are remarkably aligned.
Which is rare.
Right, and they present a strict, stepwise algorithm for clinicians. Step 1 is universal.
Always start with non-hormonal management.
Always. Aggressive non-hormonal management. Long-acting moisturizers, specifically those utilizing hyaluronic acid, which can hold moisture in the tissue, and targeted lubricants during intimacy. You have to exhaust these options first.
And step 2, because, we know from the data that non-hormonal options frequently fail to reverse true cellular atrophy.
Step 2 acknowledges that reality. If non-hormonal options fail, low-dose vaginal estrogen can be safely considered and prescribed for women with ER-positive breast cancer.
Provided they are being treated with tamoxifen.
Provided they are on tamoxifen. The guidelines officially recognize the receptor-blocking protection that tamoxifen offers.
But here's the critical question for the listener who is caught in the worst-case scenario.
What about the AI users?
Right. What if the patient is on an aromatase inhibitor? Her non-hormonal options have failed, her mucosal tissue is literally tearing, her intimacy is gone, and her daily life is just miserable.
It's heartbreaking.
The data says giving her estrogen could spike her recurrence to nearly 78%. What does she do?
For AI users, the guidelines mandate a process of intense shared decision-making.
So no simple algorithm there.
No simple algorithm here. It requires a direct, multidisciplinary conversation between the patient, her gynecologist, and her oncologist.
They have to carefully weigh the profound degradation of her quality of life against that very real statistical threat of recurrence.
Right. However, the British Gynecological Cancer Society and ACOG do suggest a really fascinating, proactive clinical workaround.
A medication swap.
Exactly. The swap. If a woman on an aromatase inhibitor desperately needs vaginal estrogen simply to function normally without pain, the oncology team can evaluate her specific tumor pathology and actually consider switching her adjuvant therapy.
They pull her off the AI.
Yes, and transition her over to tamoxifen.
Wow.
By strategically changing the systemic cancer drug to the bouncer, they create a pharmacological environment where it is suddenly safe to introduce the localized estrogen she needs to heal her tissue.
It's incredible that we have to play high-stakes chess with oncology medications just to allow a woman to walk or sit down without pain.
It really highlights the severity of the issue.
But, the scientific community is also exploring alternatives outside of traditional estradiol creams. Let's spend some time on the newer horizons.
Oh, definitely.
Starting with androgens.
This is where the research gets incredibly promising. There's a pivotal 2018 study by Davis that explored the use of intravaginal testosterone cream for breast cancer survivors on AIs.
And testosterone is an androgen, not an estrogen.
Exactly. The biology here is totally distinct. While testosterone can theoretically be aromatized into estrogen locally in the vaginal tissue, it primarily acts directly on the local androgen receptors.
Which stimulates tissue health, improves blood flow, and enhances nerve sensitivity.
Right, and crucially, it does all that without systematically feeding ER-positive breast cancer cells.
That's amazing.
The Davis study demonstrated that intravaginal testosterone significantly improved sexual satisfaction and reduced dyspareunia for women on AIs. It offers a much safer hormonal pathway.
And beyond testosterone, there's also fascinating research on ultra-low-dose estriol. Look at the clinical trials led by Donders.
Oh, the probiotic gels.
Right, investigating vaginal gels that combine estriol with live lactobacilli. It's essentially a targeted probiotic for the vaginal microbiome.
Now, estriol, or E3, is a much weaker, shorter-acting form of estrogen compared to standard estradiol, which is E2.
Right. The pharmacokinetics of estriol are highly favorable for survivorship. Because it has a very low affinity for estrogen receptors and binds to them only briefly, it provides just enough local stimulation to thicken the mucosa.
Just enough to feed the newly introduced lactobacilli and restore the acidic pH.
But crucially, the Donders phase 1 studies showed that its absorption into the bloodstream is negligible.
Highly transient.
Right, making its safety profile incredibly promising, even for cautious use in patients on AIs.
It's clear that the scientific innovation is there, but I think it highlights just how desperately we need large-scale, randomized controlled trials focused explicitly on post-cancer quality of life.
Rather than trials that only track raw survival data.
Absolutely.
Yeah.
The medical community has mastered the art of keeping these women alive, but we are still drastically behind in figuring out how to let them actually live.
So what does this all mean? Synthesizing everything we've covered in this deep dive. The long-standing dogma, the pervasive fear that a simple tube of localized vaginal estrogen is a universal, guaranteed death sentence for any breast cancer survivor. It's definitively outdated.
Completely outdated.
If you're a survivor, especially one whose cancer is successfully managed by tamoxifen, the data from massive cohorts spanning tens of thousands of women shows that localized estrogen is highly safe.
It's safe, effective, and urgently needed.
It is not systemic hormone replacement therapy. But if you are navigating survivorship on an aromatase inhibitor, the threat of systemic absorption is real.
The data is alarming there.
Yes, and finding relief requires a highly personalized, deeply cautious approach with your entire medical team, potentially exploring therapy swaps or androgen alternatives.
And if we connect this to the bigger picture, this entire situation exposes a glaring structural flaw in how regulatory bodies handle survivorship.
Oh, the FDA warning.
Right. The FDA's blanket black box warning remains permanently affixed to every single estrogen product on the market. It doesn't differentiate between a massive systemic patch and a microscopic localized tablet.
It doesn't differentiate between a patient on tamoxifen and a patient on an AI.
Exactly. Despite major medical guidelines actively creating clinical pathways for its safe use, that unnuanced warning terrifies patients and creates immense liability anxiety for physicians.
It's an outdated regulatory mechanism that actively harms patients by scaring them away from the exact relief they need.
It truly does. Survivorship has to mean more than just having a pulse.
Thank you for joining us on this exploration today. As we wrap up this deep dive, we want to leave you with one final thought to mull over.
It's an important one.
Throughout this discussion, we've talked about measuring the success of cancer treatments by looking at recurrence rates and mortality data. The hard, objective numbers.
It's survival stats.
Right. But what if the medical community started weighing the invisible, daily physical pain of the cure with that exact same objective rigor? We successfully developed therapies that starve the cancer and save the body. But if the treatment that saves a woman's life leaves her tissues so degraded that basic intimacy becomes unbearable and her daily physical comfort is destroyed, have we truly healed her?
Something we all need to think about.
Until next time, keep diving deep.